Okay, good afternoon. For those of you who are still here, if everybody's awake, it's kind of hard towards the end of the day after you guys have had a busy day of listening to all sorts of things. What we're going to talk about this afternoon is some urogynecologic issues in EDS. First of all, I'm Joan Blomquist. I'm a urogynecologist. Urogynecologists I was initially trained as an OBGYN, and then I did some extra training in what's called female pelvic medicine and reconstructive surgery. So I primarily see women who have bladder issues such as urinary incontinence, difficulty emptying their bladders, recurrent bladder infections, bladder pain, and then also prolapse, which is a herniation or bulging of the uterus, bladder, or rectum into the vagina. So a urogynecologists, some of us are trained initially as OBGYNs, some are trained as urologists, and then we all do a similar type of fellowship training. So different urogynecologists kind of come from different backgrounds, which might be important for you to know. So what we're going to talk about today is some sort of common bladder issues for EDS. So first of all, why are we talking about this? This is extremely common just in general, and because I see women as a gynecologist, we're going to primarily be talking about women, but a lot of these issues can also occur for men. This is Whoopi Goldberg, who I'm sure you all recognize, and this was about 5 years ago when she was part of an ad campaign for Poise incontinence pads. And in each of the various ads, she would dress as some famous woman from history to kind of get across the point that this can happen to anybody, anywhere, and at any time. And also that it's very common. 1 in 3 like me is what she says, and about 30% of women have incontinence. The current statistics are that about 20% of American women will have surgery at some point in their life, either for incontinence or for prolapse. So if you think about it, if 20% of women have surgery for these conditions, obviously a lot more have them that either are not being treated or are being treated with things other than surgery. And then if we look at the EDS patients, there's some varying studies and different statistics, and sometimes it's EDS versus hypermobile, depending on when the study was done and what the definition was. But prolapse, we think, is at least twice as common in EDS patients, and urinary issues are probably at least twice, and in some series up to 3 times as common. So a pretty common condition to deal with. What I picked were the 3 that I see most commonly in EDS patients in my practice. So we're going to talk about some voiding issues, which is difficulty emptying your bladder, frequency and urgency, and then incontinence. And I put neurogenic bladder up there in quotes because that's something that I see frequently, someone coming in with EDS to be evaluated for neurogenic bladder. And I just want to clarify that term a little bit. Really what it means is any bladder problem that's caused by a neurologic issue. So it could be any of these things. It could be difficulty emptying, it could be frequency, or it could be incontinence. We just have to know that it's coming from a neurologic issue. So this is particularly relevant at looking for tethered cord, because that would be a neurologic reason as to why the bladder symptoms are happening. So we'll kind of mention that throughout the talk today. So before we can talk about what's abnormal, first we need to just review a little bit about what the bladder is supposed to do and what a normal bladder looks like. So this is an image of a bladder. The bladder has a mucosal lining, sort of like the lining of the intestines. And then it's surrounded by a muscle, what we call the detrusor muscle. This is a muscle that's innervated mostly by the autonomic system, so not necessarily a bladder that you have, or muscle that you have direct control over. Then the urethra is the tube that goes from the bladder to the outside. In the female, it's about 3 to 4 centimeters long, and obviously much longer in the male. And the bladder's primary function is to be a storage place for urine. So when it's in its storage phase, the bladder muscle is supposed to be totally relaxed so that it can stretch and accommodate and hold urine without any increase in pressure. And the urethra is supposed to be closed so that no urine leaks out. And then when you get to the voiding phase, the bladder muscle is supposed to contract and the urethra muscle is supposed to relax. But obviously the bladder is not just in isolation. It's impacted by surrounding structures and other things. Well, the little tubes coming into the top of the bladder there that are labeled ureters are the tubes that come from the kidneys down into the bladder. Obviously, what your bladder does is a function of how much urine your kidneys are making. So if your kidneys are making way too much urine, your bladder could be totally perfectly normal, but you're still going to the bathroom all the time because you have to get rid of all of this volume. So what your kidneys are doing has an impact on what your bladder does. Your surrounding anatomy also has an impact on the bladder. So this is a woman that's cut down the middle, and we're looking at her from the side. In the very front is the pubic bone. Behind that is the bladder and the urethra. Behind that is the vagina with the cervix and uterus up at the top. And then behind that is the rectum and then the tailbone. So there are a couple of things I want you to notice in this diagram. The first is how close the bladder and the vagina are. It's really only about a centimeter difference. And that vagina is very important for support of the bladder. So if connective tissue isn't good and the vagina is not doing a good job supporting, then the bladder can herniate or bulge down into the vagina. The other thing I want you to notice is how close the uterus is to the bladder, and they're actually connected. Like when we do a hysterectomy or a C-section, we have to dissect the bladder off of the uterus. So if your uterus is enlarged for some reason, such as a pregnancy or fibroids or some other abnormality of the uterus, then it can put pressure on the bladder and impact the symptoms that you might have. Oh, actually, one last thing I forgot to mention. What's not shown as this diagram is between the pubic bone and the sacral bone, there's a whole bowl of muscles, and those are your pelvic floor muscles that are very important to the function of the pelvis. And we'll talk about those as we're going along too, but those muscles have an impact on how the bladder can empty. And then obviously the neurologic supply to the bladder is very important. And it's actually kind of a complex system of nerve supply to the bladder. The nerve supply is both autonomic, which is your sympathetic and parasympathetic, as well as a somatic nerve supply. And they come off at different points in the spinal cord, which is really pretty important when we think about where abnormalities in the spinal cord can occur. So the sympathetic nerve supply comes off from the thoracic and lumbar area. Up at the top there, that 10, 11, 12 is the thoracic area, and 1 and 2 is lumbar. So the sympathetic that goes to the bladder is about T11, 12, and L1. They come off, and through the hypogastric nerve is how they get to the bladder. The sympathetic system is responsible for storage, so it makes the bladder relax and the urethra contract. The parasympathetic comes off in the sacral area, so S2, 3, and 4, and those combine to become the pelvic nerve that then goes to the bladder, and that's what's responsible for voiding, so what makes the bladder muscle contract. And then the somatic nerve supply also comes down out of that sacral area, but it goes through a different nerve called the pudendal nerve and gets to the muscles of the pelvic floor and the muscle of the striated muscle of the urethra. So in situations like a tethered cord that's more likely to involve the sacral area, there might be an abnormality of the parasympathetic or the somatic part of the bladder control. So let's talk a little bit about how we evaluate patients that come in for problems with bladder function. First of all, like with anything, we need a good, thorough history. The reason I even mention this is sometimes an embarrassing thing to talk about, but it's really important to be totally open and honest with your provider and explain to them if you're having leakage issues, when is it happening, if you're having bedwetting issues. Those are all really important things that we understand how much it's impacting your life. So don't be afraid to be totally open and talk about these things. Frequently, we'll ask patients to do what's called a urinary diary, which is keeping track of how much you drink throughout the day and how much you urinate throughout the day. Sometimes we'll ask you to do it for 24 hours, sometimes more like 3 to 7 days. And that can give us a lot of information about how much is going in and when the urine is coming out, how much your bladder can hold at each of these different times, if it's more of an issue at daytime or nighttime. So we get a lot of information by reviewing that diary. Physical exam depends a little bit on what we're looking for, but in a typical physical exam, being a gynecologist, I tend to focus on the pelvic exam. We check the nerve supply to the area, usually by using a Q-tip, which allows us to assess whether the sacral nerve supply is working properly. We do measurements of different parts of the vagina, which is how we check to see if the bladder is well supported, if the uterus is well supported, and also assess the muscles, whether or not you can squeeze when we have you do that a Kegel squeeze, like you're trying to hold the urine in, and whether those muscles can relax the way they're supposed to. We frequently also do what's called this post-void residual test, which is an assessment of whether or not you empty your bladder well. We know that on average, the bladder can hold about 300 or 400 cc's, and when you urinate, you should empty at least 2/3 of that out, so there usually should be less than 100 left in your bladder after you've just gone. And so we can check that either with an ultrasound sometimes or by passing a little catheter to see how much urine is left in there. And then frequently we get to urodynamic testing, which I know you heard about if you were in the talk earlier on neurology with regards to evaluation for tethered cord. And what urodynamics does is it allows us to really understand more about what the function of what your bladder is doing. The way we do the testing is we have a little skinny catheter that literally is 1 to 2 millimeters, so it's really tiny. It goes into the bladder and it has a little pressure monitor on it. And then it has another pressure monitor that sits in the urethra. And then through that, we slowly fill the bladder up with sterile water, and we watch as we're filling to see, is the bladder having contractions? Can you feel when we would expect you to feel that there's something in there? How much can you hold before you either get uncomfortable or have a strong urge to go? And that tells us a lot about the filling phase of the bladder function. And then after the bladder is completely full, we actually have you urinate while those catheters are still in place. And that tells us whether or not the bladder is contracting the way it should and the urethra is relaxing the way it should. And that helps us to kind of assess the nerve supply and the function of the bladder. So it's a very important test frequently, especially for tethered cord evaluation. All right, so let's move on now and talk about these different conditions and what symptoms you might have, and then what are some of the treatments that we can do to make things easier. So we'll start by talking about voiding issues. Frequently when you have voiding issues, people complain about urinary hesitancy, which is the idea that you sit down to go and then nothing's really happening, or it just takes a long time before the flow starts. Frequently the stream is very slow, so you feel like you might be dribbling or just you're there very long compared to the person in the stall next to you. And then if you're not emptying your bladder well, then you frequently have to go more often because you're still walking around with your bladder half full. So we sometimes just have people come in saying, I'm going to the bathroom all the time. They don't realize that they're not emptying their bladder well, but that's really the reason that they're going frequently. And then every time you urinate, you are flushing bacteria out. And if you get a good strong stream, then you really flush the bacteria out that are normally part of the bladder. So if you're not flushing them out well, or if there's still some urine sitting in the bladder after you've gone, then it can be a setup for bladder infections. So sometimes people with this will present just with recurrent bladder infections. And then if you really aren't emptying your bladder well and there's higher pressure in the bladder, it can actually reflux up to the kidneys and could cause some kidney trouble. So it's important that we evaluate that. So there are a couple of different reasons why people can have difficulty emptying their bladder. If we think back on how the bladder is supposed to work when it empties, we're supposed to have the good bladder contraction and the urethra is supposed to relax. So if the bladder isn't contracting normally, that can be a problem, and that's called an inadequate detrusor contraction. Or if the urethra isn't relaxing properly, then that can be a problem. The other thing is if those pelvic floor muscles are really tight, what we call high tone pelvic floor, then even if the bladder function is normal, the urine just can't get past because the muscles of the pelvic floor are blocking it. And then the final thing that I'll show you some pictures of is if the pelvic organs are prolapsing down, it can sometimes interfere with emptying. So let's talk a little more detail about the last three, because those are the three that I think are the more common in the EDS population. So inadequate urethral sphincter relaxation is just that the muscle of the urethral sphincter isn't relaxing normally. And that has some parasympathetic supply, but it also has some somatic supply. So it could be related to issues with tethered cord. Sometimes physical therapy can be helpful for this. Usually physical therapy is more for relaxing the pelvic muscles, but sometimes you can actually learn to relax that muscle a little bit. You'll hear me talk a lot today about pelvic physical therapy. A pelvic physical therapist is someone who is specialized in incontinence and prolapse, and it's not a regular physical therapist. They have to know how to really work with the pelvic floor, and they can be your friend. So it's really important to get to know your pelvic physical therapist in your area. So they can be very helpful for this. Sometimes we use medications. The two most common are Cardura and tamsulosin. Tamsulosin is the same thing as Flomax, which is what men with prostate problems sometimes are on. They work by attaching to a receptor in the urethral sphincter so that the urethra relaxes. Now, the only downside of these medicines is that they can drop your blood pressure a little bit. So in some EDS patients who've had POTS or other orthostatic hypotension issues, these sometimes aren't very well tolerated. And then sometimes we have to do self-catheterization, which is the idea of occasionally throughout the day passing a little catheter into the bladder to drain it if we really can't get you to empty your bladder well. And although that sounds awful, if it gets to that point, people usually feel so much better to be able to empty their bladder that they're really okay with it. And there are all sorts of convenient catheters that come self-lubricated and are pretty easy to use, so it's not as terrible as it sounds, although it always does make people nervous. The high-tone pelvic floor that I mentioned, the top picture is looking at the pelvic floor from the bottom up, where you can see all of those good thick muscles there. The bottom one is looking from the inside down, and you can see all of those muscles attached to the bones of the pelvis. Now, if you think about EDS patients, especially those who have hip issues or joint laxity in the pelvis, your body's response to make up for that laxity is to tighten these muscles. So in some respects, that's good. We want the muscles to be doing their job, but sometimes they can get so tight that they can actually spasm and then can make intercourse difficult and can make emptying your bladder and emptying your bowel difficult. So that's when it gets to the point that we call it high-tone pelvic floor. This is where physical therapy can be very helpful. They do various techniques of teaching you how to relax the muscles. Sometimes it's massage therapy and various relaxation techniques. Sometimes, though, we need to use muscle relaxants. Usually we can make those into vaginal suppositories. The one that we probably use the most is either baclofen or Valium. That can be made into a small little suppository that goes into the vagina, and then it does its work locally, so you're less likely to have the systemic side effects of taking a muscle relaxant. We don't like to use those for the long term, but they can be very helpful, especially if you can't initially tolerate physical therapy. Sometimes using the suppositories for a little bit or right before going to work with a physical therapist can really help so that then they can actually make things better. And then I wanted to talk a little bit about prolapse and how that can interfere with emptying the bladder. So the diagram on your left is the normal pelvis. So again, I showed that to you before where you can see the bladder and the vagina. The image on the top one on the right is when someone has lost support of the front wall of the vagina so that the bladder is bulging down into the vagina. That's what we refer to as a cystocele. And on the bottom shows when someone has lost support of the ligaments that support the uterus so that the uterus is dropping down into the vagina. And I think if you look closely at those, you can see how both of those situations can put a little kink in the urethra so that then the urine has to kind of go around this kink or gets blocked in order to come out. And so that can make emptying the bladder difficult. And as I mentioned, these conditions are more common in EDS patients. So the way that we treat that, sometimes if it's mild prolapse, pelvic exercises can still make a difference. Or we sometimes have people use Pessaries, which is a device that looks sort of like a diaphragm, slides into the vagina and helps to support things up. Or we sometimes have to do surgery. So let's move on and talk about urinary frequency and urgency. And frequency is just the idea of going to the bathroom more often than you think you should. We used to say it needed to be 9 times a day in order to qualify as frequency. Now we just say anything that the patient finds bothersome. So for most people, that's more than every 2 hours or so that people would find that bothersome. And then urgency is the idea of feeling like you get the signal and then you hardly have enough time to get to the bathroom. Some people who have this have incontinence with it, which we call urgency incontinence, which means they can't make it every time to the bathroom. And other people can, but they just have that strong urge and know if they delay anymore, they're not going to make it in time. One of the things that can cause this is what we were just talking about, voiding dysfunction. So that if you're not emptying your bladder well, then you need to go more frequently. The second is overactive bladder that we're going to talk about, and then interstitial cystitis. So let's talk about overactive bladder. If you remember back to what we talked about as to how the bladder works, the muscle of the bladder wall is called the detrusor muscle, and that's supposed to contract when we go to empty the bladder. In people who have overactive bladder, the bladder or the muscle is supersensitized for some reason, and so that bladder muscle is having lots of contractions or spasms before the bladder is really as full as it should be. And so every time that bladder contracts, you feel it as an urge or a need to go to the bathroom, and then if it's a strong enough contraction, it can actually make you leak urine. We don't know exactly why this happens. For some people, we can kind of pinpoint it to that it's something that's irritating the lining of the bladder wall, like a bladder infection or a kidney stone or something that they're eating or drinking. A lot of times we think it has to do with the nerve supply to the bladder, though, that for some reason those nerves are irritated. For example, arthritis or tethered cord or something else that could be compressing those nerves that's making the bladder contract more. So a number of different things. We always start with our most conservative treatments, and for a lot of people, behavior modifications can make a big improvement in their symptoms. Weight loss, even up to 10 pounds, has been shown to make a difference for people who are overweight, so that's something that we always discuss. Avoidance of bladder irritants is probably the biggest behavioral thing that can help. The biggest culprits are caffeine. Caffeine is irritating to the bladder, but it's also a diuretic, and so it's a little bit of a double whammy. Things that are acidic, so oranges, grapefruits, tomatoes, pineapple, all the good stuff. For some people, sugar substitutes is also an irritant, and alcohol. So I would say the two worst things that I hear are Diet Coke and Diet Pepsi, because they have caffeine and they're acidic and they have sugar substitutes. And then some of the high acid coffees. So it's important to remember, even if you go to a decaf coffee, some coffees are still very acidic, and that can be irritating to the bladder. And then the other thing is fluid management. So just thinking about overall when you're drinking your fluids throughout the day compared to when you have problems with the urgency and frequency and what you're drinking. Now this obviously gets a little tricky if you have POTS or things that you need to be increasing your fluids, but to kind of work together with your different doctors to see if there's anything that can be altered with your fluid management. The next is the idea of the pelvic floor exercises. So again, working with your physical therapist. Now this seems a little odd if you think about that what we've talked about is this is because the bladder muscle is contracting too much. And I said that that's a muscle that you don't have control over. But if you squeeze the pelvic floor muscles, it sends a signal through the spinal cord that tells the bladder muscle to relax. So you do have an indirect control over the bladder muscle, and that's how this works. If you go to a physical therapist, what they generally do is use some biofeedback. Sometimes they use electrical stimulation to help recruit the muscles if the muscles aren't doing anything. They do various Kegel exercises and different Pilates moves. A lot of the Pilates moves make you use the pelvic floor muscles also. Working with a physical therapist is about 70% effective for this. So that's actually one of the most effective treatments that we have. If we teach you to do the exercises and give you just a home program, just your gynecologist talking to you about this, it works about 10% of the time. So there's something about that one-on-one with a physical therapist that really does make a difference for this. Next is medications. There are a slew of different medicines that we see on TV now all the time for overactive bladder, and they're in two main categories. The first is anticholinergics, which have been around for a long time, and then beta agonist is the new one on the block that's been around for about 4 years or so. The anticholinergics, they basically all work about the same. In studies, they're about 60% successful. The main side effect for the anticholinergics is a dry mouth or constipation. The beta agonists, in a small percentage of people, it can make their blood pressure go up, so that's something that we need to monitor. Both of these work by the medicine attaching to a receptor in the bladder wall to prevent the contractions from happening. Generally, the next couple of things that we're going to talk about are things that we get to if these other treatments haven't worked. This next category is what we call nerve stimulation. And the idea is that if we overstimulate the nerve that goes to the bladder, it actually makes the bladder relax. And there are two different ways that we can do this. This one, PTNS, or percutaneous tibial nerve stimulation, we do in the office. We put a tiny little needle that's about the size of an acupuncture needle into the ankle, right where the tibial nerve is. And then we attach that to a little stimulator box, and you sit there for about a half an hour with that being stimulated. And that signal travels up the tibial nerve, goes into the spinal cord, and then goes to the bladder. And so that's how it works. This is time consuming because you come once a week for 12 weeks. And we frequently don't see a response until between 6 and 8 weeks when people start to notice improvement. And then we don't know for sure. This is relatively new, meaning a few years. So the initial studies were really looking at this 12-week time period. But we think people then need some sort of maintenance. So we'll frequently have people come back once a month or kind of help, have them pick how long they think they need based on if their symptoms start to come back between sessions. This is about 60% successful. And then there's a little more of a permanent way to stimulate that nerve. This is called Interstim, or sacral nerve stimulation. The idea is that we surgically put a tiny little electrode that goes through the S3, the hole in the sacrum that stimulates the S3 nerve root, and then that gets attached to a battery pack, which is like a pacemaker that then we bury underneath the skin and the buttocks, or sort of under the fat pad, so you can't really feel it. And then you have a little remote control that you can turn it on and off, and most of the time it's on. This is also about 60% overall. We do a test phase first, and about half the people do well with the test phase. If you do well with the test phase, then we put the permanent one in, and so then that's about 90% successful. So overall, it's still about 60 to 70%. The nice thing about this is if it works, then you're good for quite a while until the battery dies. On average, the battery lasts about 5 years, and then we have to go back and put a new battery pack in. And then the final option is Botox. I'm sure you've heard about Botox being used for all different types, sort of overactive muscles in the body. So if we inject Botox into the bladder muscle, then it paralyzes the muscle so it can't have as many of the contractions or spasms. Generally, we do this in the office. So we put some numbing medicine into your bladder, let it sit there for about a half an hour, and then we look inside with the cystoscope. And through the cystoscope, we have a little needle that injects in about 20 different places in the bladder, so hopefully that it sort of spreads out over the whole bladder wall. This is about 70% successful also. The nice thing about it is if it works, then you're good for quite a while. It doesn't last forever, but on average 6 to 10 months before we have to repeat it. So it's nice to not have to be going to physical therapy or taking a pill or doing something on a daily basis to deal with this if it works well. The negative of it is a procedure to do, and sometimes it works too well, in that then you can't empty your bladder well. So we always tell people there's a possibility that you would have to catheterize yourself for a little bit if it works too well. The risk of that is about 5%. And then there's a slight increased risk of bladder infections. We think, again, because it makes the stream slower, so you might not be emptying quite as well. So the next thing I want to talk about is interstitial cystitis, or painful bladder syndrome. And this is the other thing that can make people have to go to the bathroom frequently. Usually when you go to the bathroom frequently for this, it's not because you feel like you're going to leak urine, because it's not that the bladder's having a contraction, but it's because you're uncomfortable and you get like a painful, for some people it is really pain, for others it's a pressure or just an uncomfortable feeling in the bladder area that feels better when you empty your bladder. These are just two different definitions from the American Urological Association and the International Continence Society about what the definition is. Basically what we discussed, just an uncomfortable feeling in the bladder that makes you feel like you need to go more frequently. We don't know exactly what causes interstitial cystitis, but there's a number of different theories out there that it might be autoimmune, it might be a systemic disease, it might be related to neurogenic inflammation. We do know that if we do biopsies of the bladders of people with interstitial cystitis, that they have more mast cells, so there's some theories about mast cell activation as being or at least involved in it. We do know that the lining of the bladder wall is abnormal, and that seems to allow tiny little electrolytes to get through and irritate the nerve endings underneath. And so it most likely is multifactorial in that there might be some inciting event that we frequently don't know what it is, but then all of these different things probably play together to make the bladder super sensitized and just, irritated very easily with any stretching or distension. We don't really know if this is more common in EDS patients, to be honest. I do see it quite a bit. It is more common in people who have IBS and who have other autoimmune things, or just other chronic pain issues. So it's kind of hard to decipher that out. But as far as I've been able to find, there aren't any series specifically looking at this in EDS patients. The diagnosis is based pretty much on ruling out other things that we know can cause this, but it's also sometimes just based on doing questionnaires and asking questions about what all of your symptoms are. We used to have to do a cystoscopy to diagnose it and have characteristic changes that we would see at the time of cystoscopy, but those criteria are no longer necessarily relevant. But this is just a picture of what a bladder might look like in someone who has interstitial cystitis. The normal bladder is very smooth and doesn't have the little red dots in there. In this bladder, after stretching it, the bladder wall kind of responded by bleeding a little bit and sometimes even getting ulcerations. So when we talk about treatment for this, we sort of go through different lines of treatment. And generally about 50% of people will respond to the first-line treatments. Those generally are relaxation and stress management. We know that this is more common when people are in higher stressful situations. Pain management is geared at this point more at trying to decrease irritants of the bladder. So this calcium, this first one is called Preleaf, is the brand name. And what it is basically an antacid for the bladder. So it's kind of like taking a Zantac for your stomach. It gets concentrated in the urine and takes acidity out of the urine. Sometimes even if you're being really careful about what you eat and drink, your urine might still be acidic. So the Preleaf can really help with bladder pain. The next is also called Pyridium or Azo, which you may have taken when you've had a bladder infection in the past. It turns the urine kind of a bright orange, and it really just sort of numbs the bladder, and that can be very helpful. And then the final is aloe vera. The aloe vera plant, as I'm sure your mother might have had in the kitchen, and you would break off a little piece if you had a burn, and the juice of the aloe vera helps to soothe burns by decreasing the nerve ending sensitization. There are tablets that are designed specifically for IC patients that are concentrated aloe vera that sit in the bladder and help to decrease burning and pain that way. It's important to get the tablets that don't have citric acid in them because the citric acid could, of course, irritate the bladder. And then behavioral modifications, the tendency when you have to go to the bathroom frequently is to say, I'm not going to drink anything and then I won't have to go as much. But that's actually counterproductive because it makes the urine more concentrated, which is more irritating to the bladder. So a lot of times it's just a matter of educating about making sure you're drinking enough fluids and avoiding things that are irritating to the bladder, and that can make a big difference. When that's not enough, then we get to our second-line treatments, which include physical therapy. Now, this is a different kind of pelvic physical therapy. It's not working on tightening the muscles. It's more geared towards relaxing the muscles. And with any kind of pain physical therapy, it might be pressure point type things. And then there are other medications that we sometimes use. Amitriptyline, I know you've heard about for other disorders for EDS. Cimetidine is another antacid. Hydroxyzine is an antihistamine, so that has to do with mast cell release in the bladder. And then Pitocin polysulfate is Elmiron. The idea behind that medicine is it actually helps to rebuild the bladder wall so that the bladder wall is more normal. That unfortunately takes a really long time for it to work. Generally people are on it for 3 to 6 months before we know if it's even making a difference. For people who can't tolerate medicines by mouth or just don't want to go that way, we sometimes do instillations into the bladder of a cocktail of medicines. And the idea is this cocktail of medicine kind of recoats the bladder, decreases inflammation, decreases histamine, and can be helpful in that regard. And then more advanced pain management for some people. This is just an image of like the myofascial trigger point therapy, which just to emphasize that we do different types of physical therapy for interstitial cystitis. And then sometimes we get to more advanced treatments, the third-line treatments. The cystoscopy with stretching of the bladder, we think actually sort of damages the bladder a little bit, and then it might heal more normally after we've done the stretching. Neuromodulation is, again, the same thing that we talked about for overactive bladder. So the interstim, the implantable thing into the sacrum, has been shown to be helpful for interstitial cystitis. And Botox is still considered a little experimental, but we do sometimes use that for IC. So then in the last couple minutes, I just wanted to talk a little bit about stress incontinence. We've talked about urgency incontinence already. Stress incontinence is more the kind of incontinence that happens when you do something physical, like cough or laugh or sneeze. This is when there's an increase in intra-abdominal pressure on the bladder. As you can see in this image in the lower, when there's pressure on the bladder, then the tissue between the pubic bone and the urethra helps to hold the urethra in place to decrease leakage from happening. And if that tissue is broken or stretchy, then there's not the support that the urethra needs, so then when there's something like pressure on the bladder, that can make you have some leakage of urine. And since this tissue is made of collagen, it's definitely more likely in EDS patients that stress incontinence can occur. We also see this more commonly after people have had children, and vaginal deliveries in particular seem to do some damage to the tissue in that area. There's basically 4 options for treatments for this. The first is pelvic exercises again. I told you you get to know your pelvic floor physical therapist for all sorts of bladder issues. And if you think about that, the idea is the stronger those muscles are, the more likely they are to be able to support the urethra. Just have a few pictures of this, which we won't go into. It's actually kind of interesting that the Kegel exercises, this Dr. Kegel in 1948 first noticed that if women did pelvic exercises, that they would have less incontinence. So we've known about this for a very long time, and it still is our mainstay of treatment. As I mentioned, sometimes we do electrical stimulation with the physical therapy. The second for stress incontinence is a pessary. So it's the idea of putting something in the vagina that supports the tissue underneath that urethra, so that then when there is pressure, you're less likely to have leakage. We mentioned the pessary with regards to prolapse, and this one just has a little extra knob that sits under the urethra, which is how it works. These are about 50% successful. If they work, it's great, and particularly if people only leak when they do certain activities, they might just put this in before they go to the gym or before they're going to go out or something like that, but you don't have to wear it all the time. This is called Empresa, which you may have seen a commercial for. It's available over the counter, and it looks like a tampon. It goes in like a tampon, and then instead of having an absorbent tissue, it has a sort of very soft plastic device that opens up that then supports the urethra. So the idea is it works similar to the way a pessary works, but it's something that you don't have to see a doctor for to get fitted for. You can just get it over the counter and do it on your own. These can stay in for 8 hours, and you can only use one a day. So they're not ideal for people who are leaking all the time, but again, if you just leak under certain conditions that you can kind of predict. And then sometimes we do surgery. The idea behind the surgery is to re-support the area around the urethra. The most common surgery that we do is the sling surgery. You can see the sling here is sitting loosely in the picture on the left, and then when there's increased pressure, it tightens a little bit, which is what helps with the leakage. We can make the slings out of your own tissue, or we can use synthetic material to do the slings. And these are about 90% successful. So the most invasive, but also the most successful. And then the final option is some injections into the urethra. The idea that if we bulk the urethra up a little bit, there'll be more resistance to flow, and that can decrease incontinence. We actually generally do this in the office, so we look inside the bladder with a cystoscope, and then on 2 little points in the urethra, we inject this bulking material that helps to support things. It's great in the sense that it's easy to do. It's about 60% successful, so not as successful as we'd like it to be, and it doesn't last forever. So it's sometimes better for our older patients who maybe don't need quite as much urethral support, but it's something that most likely would need to be done pretty much every year to maintain its effectiveness. So in summary, I think some of the unique aspects with regards to EDS to think about are the involvement of the pelvic muscles. Because of the joint laxity, the pelvic muscles can be tighter, and we need to think about that when we're evaluating for bladder symptoms. The other is the whole idea of the tethered cord, and tethered cord can certainly have an impact on bladder function. Mast cell activation might be involved in interstitial cystitis. That hasn't been proven, but there might be a link there. POTS can certainly complicate the treatment for bladder problems. Not that one causes the other, but we just have to be aware of it and think about that. And the same is obviously true for multiple medications. We have to be careful about too many medicines and how they interact. And the recommendations that I would have is to be sure, number one, that you are dealing with a knowledgeable provider with bladder issues, to make sure that they are aware of EDS and all the potential confounding things that might be going on. Secondly, to start with conservative treatments first, because they really do work very well for a lot of the bladder conditions. And finally, to get to know your pelvic physical therapist, because they will be your friend. All right. Thank you. I'll be around to take questions.